Hello and welcome everyone. Chalo, let's get our class started. Today we're going to dive into a really fascinating world, the world of female hormones. We'll be talking about the star players, estrogens and progestins, and also some very clever drugs that we doctors use to influence them.
So here's a quick look at our plan for today's lecture. We'll start by just saying hello to these hormones, then we'll get into the details of estrogen, tackle the very big debate around HRT, and see how we can control estrogen's power. After that, we'll talk about its partner, progestin, and finally, we'll tie it all together with the current clinical guidelines. Okay, let's begin.
All right, first things first. Before we get into all the complexities, we need to properly meet the two main characters of our story today. These are the hormones that are at the absolute heart of everything we're going to discuss. Now have a look at this. This slide shows you the basic chemical structures we're talking about. On the left, that's natural progesterone. And on the right, you have a synthetic version, 19-nortestosterone. Just look at how similar they are. But notice those small, tiny differences? It's these little tweaks that make a world of difference in how they act inside the body. A fantastic example of just how precise pharmacology can be.
Okay, so let's move on to our first big topic, estrogen. I like to call it the body's architect. We're going to explore what it does and, just as importantly, how we figured out the best ways to deliver it as a medicine.
So, here's a question I love to ask. It's a fundamental one, something every single one of you should be able to answer. If estrogen is a natural hormone, something our body makes, then why can't a patient just pop a simple pill? Seems logical, nah? But the answer, my friends, is all about our amazing and sometimes very tricky liver.
And here is the reason. It's something called the first-pass effect, or first-pass metabolism. You can think of the liver as a super strict security checkpoint for anything you eat or drink. When you take natural estrogen by mouth, the liver grabs it on its first pass through and just breaks it down, so much so that almost nothing active gets into your main bloodstream. It's basically deactivated before it even gets a chance to work.
So, how do we solve this? How do we get around this problem? Well, this is where some clever pharmacology comes in the form of the transdermal patch. Think of it like a VIP pass. It completely bypasses that liver security checkpoint. You see, it goes straight into the blood. Now look at this comparison. Oral estrogen hits the liver hard, making it produce more clotting factors, and that increases the risk of dangerous blood clots. But the patch, it just sneaks right past, delivering the hormone directly into the bloodstream and avoiding that whole risky business. A very smart solution.
And understanding these delivery methods is absolutely key, because it brings us to the two main reasons we use estrogens in medicine today. One is for contraception, and the other is for hormone replacement therapy, or as we all call it, HRT.
Okay, let's now get into what is probably one of the most debated topics in all of women's health: hormone replacement therapy for postmenopausal women. This is where, as a doctor, your clinical judgment is tested because you are constantly balancing some incredible benefits against some very serious risks.
First, to understand the treatment, you have to understand the problem, right? Menopause isn't just one thing. It can bring a lot of challenging symptoms. You have the vasomotor symptoms, things like hot flashes and night sweats. You have urogenital atrophy, which causes dryness and infections. Then there's the big one, osteoporosis, bone loss that can lead to fractures. And on top of it all, psychological issues like mood swings and anxiety.
And the data is very clear on this. HRT works. It works incredibly well for these symptoms. It gives almost immediate relief from hot flashes, it can reverse those uncomfortable atrophic changes, and, so importantly, it stops bone loss in its tracks, which means a lower risk of fractures. For so many women, it's a complete game changer for their quality of life.
But, and this is a huge but, we cannot, absolutely cannot, ignore the risks. Big studies, like the Women's Health Initiative, they uncovered some really serious dangers. We're talking about a higher risk of stroke, blood clots, and even certain cancers. And there's also evidence it might double the risk of dementia in women over 65. This right here is the central dilemma of HRT.
All right, let's change gears a bit. Now we're going to look at some very sophisticated drugs. Drugs we use to fine-tune and control the power of estrogen, especially when we're dealing with cancers that are sensitive to it, like breast cancer. This is where pharmacology gets really elegant.
So first step, we have the SERMs. That stands for Selective Estrogen Receptor Modulators. The name tells you everything. Think of a SERM as like a master key. It can act like estrogen in some parts of the body, but it blocks estrogen in other parts. For instance, a drug like tamoxifen blocks estrogen's effects in the breast tissue, which is great for fighting breast cancer, but it acts like estrogen in the bone, helping to keep it strong. Very clever, right?
Then we have a totally different strategy, the aromatase inhibitors, or AIs. Now these drugs, they don't bother with the receptors. Instead, they go straight to the source. They basically shut down the estrogen factory in the body. They block an enzyme called aromatase, which is needed for the final step of making estrogen. The result? Estrogen production pretty much stops everywhere. A very powerful approach.
Now this table is super important. It really lays out the pros and cons, the trade-offs between these two big drug classes. Look closely. With tamoxifen, you get a plus point for bone health, but you get a big minus for endometrial cancer and blood clot risk. See? Now, letrozole, it doesn't have those risks, but, and this is a big but, it can actually make bone loss worse. So what does this tell you? It tells you there is no one-size-fits-all answer. The choice of drug has to be tailored for each and every patient.
So far, we've been focused mainly on estrogen. But estrogen doesn't work alone. It has a very important partner, and to get the full picture, we have to understand progesterone. It plays a very different but an equally critical role in the body.
The name itself gives you a clue, progestin, as in pro-gestation. Its main job is to prepare the body for and support a pregnancy. It gets the lining of the uterus, the endometrium, ready for an embryo to implant. It makes the cervical mucus thick to block sperm. It gets the breasts ready for lactation. In simple terms, its whole purpose is to create a nurturing environment for a potential pregnancy.
And this brings us to a golden rule of HRT. This is something I want you all to remember forever. For any woman who still has her uterus, you must give a progestin along with the estrogen. Why? Because unopposed estrogen will make the uterine lining grow and grow, a condition called hyperplasia, which can lead to cancer. Progestin acts as the protector. It opposes that growth and keeps the uterus safe. Non-negotiable.
Okay, let's bring everything we've talked about together. We've seen the good, the bad, the complex. So, after all this balancing of risks and benefits, what is the current thinking? What are the bottom line guidelines for us in clinical practice?
This slide is a perfect summary of modern best practices. Let's quickly go through it. The number one reason to use HRT today? For those vasomotor symptoms, the hot flashes, mainly in women under 60. The mantra is, smallest effective dose for the shortest possible time. It's no longer our first choice just to prevent osteoporosis. And the golden rule we just talked about, estrogen alone for a woman without a uterus, estrogen plus progestin for a woman with a uterus. And finally, the most important point, every patient is unique. The decision is always made on an individual basis.
So, I'll leave you with this final thought to ponder. Hormone therapy is truly a double-edged sword. It's a powerful tool. It can do incredible good, but it also carries significant risks. The challenge for you as the next generation of doctors is to figure out how we can wield this sword better. How can we get smarter about our therapies to maximize all the benefits and minimize all the harm for our patients? That is the question. Thank you for your attention.
Hello, everyone, and welcome. Today, we're diving into something you'll see almost every single day in your clinical postings, whether it's OBGYN or even general practice, and that's progestins and contraceptives. Getting this right is absolutely fundamental. So this session is all about building that core foundation for you. Chetal, let's begin.
Look, we're going to build this knowledge step by step, brick by brick. First, we'll start with the foundation, the progestin molecule itself. Then we'll see how we use it, and, interestingly, its complete opposite, the antiprogestins. After that, we hit the main application, hormonal contraceptives. We'll figure out how to choose the right one, and most importantly, how to balance the risks and benefits for your patient. This flow is really designed to stick in your memory, especially for your exams.
All right, Section 1, the foundation. In pharmacology, if you don't truly understand the original natural molecule, you'll never really get a feel for all its synthetic cousins. So our starting point has to be the prototype, the hormone our body makes naturally, progesterol.
Now just look at this slide and focus on that half-life. Can you believe it? Just 5 to 7 minutes. I mean, imagine asking a patient to take a medicine every 10 minutes. It's just impossible, right? The liver's first-pass metabolism is so aggressive that natural progesterone is practically useless as an oral drug. And this was the big problem that science had to solve.
And here is the solution. It's actually brilliant. Scientists came up with synthetic progestins. And the crucial point here, the absolute game changer, is the difference in half-life. We're going from a few minutes to 8 to 24 hours. This means we can finally give it as a simple pill, it lasts so much longer in the body, and it's way more potent. We basically engineered a much, much more useful tool for our clinical practice. So we have these powerful synthetic tools now. This next section is all about our clinical toolkit. When do we use them, and what are the potential side effects we absolutely have to watch out for? See, it's not just about knowing the instrument, it's about knowing how to play it safely. Okay, everyone, I want you to put a big star next to this slide in your notes. Seriously, this is a Viva favorite and a super high-yield exam topic. The uses are so broad, from the most common one, contraception, to managing things like dysfunctional uterine bleeding and endometriosis, all the way to hormone replacement therapy. You just have to know these indications. You know, a good doctor knows the indications, but a great doctor knows the side effects inside out. Your patient is going to ask you about things like mood swings and irregular bleeding, but you also have to be aware of the more serious stuff, the metabolic effects, like how some of the older generation progestins can lower the good cholesterol, the HDL. Remember, patient safety always comes first. Okay, now for a complete change of pace. We've been talking about what progestins do, but what about drugs that do the exact opposite? Let's flip the coin and explore the counteragents, the antiprogestins. This is a really powerful and very distinct class of medication. And the key player here is a drug called mifepristone. Its mechanism is actually beautifully simple, but so powerful. Think of it like this. It sits on the progesterone receptor, but it doesn't switch it on. It's a competitive antagonist. It just physically blocks progesterone from doing its main job, which is maintaining the lining of the uterus. Now, this slide is pure classic pharmacology, and I can almost guarantee you it'll be an exam question. You have to understand this cascade. So, step 1, mifepristone blocks the receptor. Okay, this withdrawal of progesterone support makes the endometrium unstable, which then, and this is key, leads to the release of prostaglandins. And these prostaglandins are what drive all the next steps: the uterine contractions, the dislodging of the conceptus, and the softening of the cervix, which all lead to termination. All right, let's move on now to the single biggest use of these hormones all over the world, and that is, of course, contraception. This is a topic where your knowledge is going to directly impact the lives and choices of millions and millions of women. So let's really get into the details. So how do these combined estrogen and progestin pills actually work? Well, the main mechanism, the biggest slice of this pie you see here, is simply stopping ovulation. That's it. But it doesn't stop there. The progestin also has these backup effects. It makes the cervical mucus really thick and hostile to sperm, and it makes the uterine lining, the endometrium, totally unsuitable for implantation. It's like a 3-level security system. So we have the combined pill, and then we have the progestin-only mini pill. What's the real difference? Well, just look at the efficacy. The combined pill is like a fortress. It's over 99% effective, mainly because it consistently stops ovulation. The mini pill, on the other hand, is a little less effective because in maybe a third of women, ovulation might still sneak through. So why would we ever use it? Well, we use it when a patient has a contraindication to estrogen. That's the key. Look, taking a pill every single day doesn't work for everyone. Life gets in the way. So we have other options that are tailored to different needs. For emergencies, there's the postcoital pill. And for women who want to, set it and forget it, we have long-acting injectables like DMPA that you take only every 3 months, subdermal implants that can last for years, and even transdermal patches you change just once a week. The whole goal is to find the best fit for the patient's actual life. And this is where the theory meets reality. In this section, this is where we learn to be doctors. We take all this pharmacology we've learned and we apply it to the real-world scenario of helping a patient choose the absolute best method for her life and for her health. This table gives us a really clear side-by-side comparison, but I want you to look at one row in particular: fertility return. With pills, fertility bounces back super quickly, usually within a month or 2. But with injectables, look at that. It can be delayed for many, many months, sometimes even over a year. This is such a critical point to discuss with a patient, especially one who might be thinking about planning a family in the near future. And now for the final, and I think the most critical analysis, the risks and contraindications. You have to remember, every single prescription is a balance. Our job is to weigh the benefits against the potential harms for that specific patient sitting right in front of us. This is where good clinical judgment is, well, it's everything.
Let's talk about the risk that everyone worries about, blood clots, or VTE. So, how big is this risk really? Well, this number shows us the risk is about 2 to 3 cases for every 1,000 women using the pill for a whole year. Okay, so it's a small risk, but it is very real. And here's the crucial piece of context you need for counseling your patient. The risk of a clot during pregnancy is actually much, much higher. And that's exactly why we have to screen so carefully for other risk factors like smoking or a family history before we even think about prescribing. This slide, you must memorize this slide. I'm serious. There's no negotiation here. These are the absolute red flags. If your patient has any one of these conditions, you simply cannot prescribe a combined oral contraceptive. A history of blood clots, severe high blood pressure, active liver disease, these are total, complete contraindications. Your patient's life depends on you knowing this list by heart. But let's end this whole risk analysis on a positive note, shall we? Because these pills, they come with some pretty fantastic bonus benefits. They significantly reduce the long-term risk of both endometrial and ovarian cancers. They make periods lighter, more regular, and way less painful. The truth is, for many women, these non-contraceptive benefits are the main reason they use the pill in the first place. So, I want to leave you with this final thought. As future clinicians, please never think of these medicines as being just for contraception. I want you to always ask yourselves the bigger question: how are these incredibly powerful hormones reshaping your patient's overall health, both for today and for the rest of her life? TK? Good. That's all for today.
All right, class, settle down, settle down. So, today we're going to look at two completely opposite ends of the pharmacology spectrum. First, we'll tackle the huge challenge of creating a contraceptive pill for men, and then we'll switch gears completely and talk about the precise science of how we can start labor in women. Two very different problems. Pay close attention. So, let's just jump right in with a question that I'm sure many of you have wondered about yourselves. The female pill has been around for more than 60 years, Yar. So where is the male pill? Why is it proving so incredibly difficult to develop?
You see, to really understand the problem, you first have to appreciate the sheer scale of the biological challenge. It's not just a simple chemical problem. It is fundamentally a problem of mathematics. It is a numbers game.
Just look at these numbers here. This is the first massive hurdle. For a woman, what's the goal? You just have to stop a single ovum per month. That's it. But for a man, my God, you are talking about stopping millions and millions of sperm, not per day, but in every single ejaculation. The scale is it's chalk and cheese, completely different.
And it's not just about the numbers, okay? There are some really tricky biological problems too. First, the process of making sperm, spermatogenesis, is a 64-day cycle. That means any drug you give is going to be slow to start working and then slow to wear off. That's not ideal. Second, and this is the killer, sperm production is tied directly to testosterone. So if you try to suppress sperm production, you almost always end up hitting the man's testosterone levels. And what's the result? Loss of libido, impotence. That's a complete non-starter, no? And finally, you have to think about motivation. Men don't get pregnant, so their calculation of the risk versus benefit for taking a daily medicine is just very different.
So as you can imagine, scientists have thrown everything at this problem. Let's take a look at the history of these attempts. It's basically a story of hitting one brick wall after another.
Okay, so what was the first, most obvious idea? Let's try anti-androgens or estrogens. And sure, they work to suppress sperm production, but the side effects? They were total deal breakers. You either got a complete loss of sexual desire or you got feminizing effects. So obviously, that was never going to work.
All right, so that didn't work. What about other hormonal tricks? They tried giving androgens directly, but it just wasn't reliable enough. Then they tried these fancy GnRH analogs, more sophisticated hormonal drugs. But guess what? We came right back to the same old problem: impotence. Why? Because you're still shutting down the body's own natural testosterone production.
So you see the pattern, right? You can't just use a sledgehammer here. For example, they even tried cytotoxic drugs. Now these are the kinds of drugs we use in cancer chemotherapy. They kill rapidly dividing cells, and sperm are rapidly dividing cells. So, did it work? Of course it worked. But you can't put a healthy man on cytotoxic drugs for years. They are simply too toxic for general long-term use. Safety has to be number one, always.
But then, for a little while, there was this one compound that looked really promising. It was called gossipol. It came from cottonseed and was studied extensively in China. Now this was exciting. Why?
It was non-hormonal, it stopped sperm production, and, this is the key part, it didn't affect libido at all. Everyone thought, this is it, we found it. But there were two huge fatal flaws. First, for about 10% of men, the infertility it caused was permanent. It never came back. And even worse, it could cause a very dangerous condition called hypokalemia. Basically, your blood potassium levels would crash. This could lead to severe muscle weakness or even paralysis. So that was the end of Gossip Hole. Another dead end.
Okay, so that is the story of trying to stop a biological process and how incredibly difficult that has been. Now, let's completely change gears. Let's look at the story of starting a process, and one that we have learned to control with amazing precision.
Okay, so our next topic, uterine stimulants. The medical term you must know is oxytocics. As the name suggests, these are drugs that increase the motility, the contractions, of the uterus.
Have a look at this chart. You can see there are a few main types, right? You've got your ergot alkaloids, you've got prostaglandins, and some others. But the one we are going to focus on today, the one that is the absolute star of the show, is in that first column, the workhorse of the labor room, oxytocin.
So let's really dive into oxytocin. How on earth did this hormone, something our own bodies make naturally, become one of the most critical and important drugs in modern obstetrics?
So what is it exactly? Well, technically, it's a non-peptide hormone. That just means it's a small protein, only 9 amino acids long. It's produced in the hypothalamus and released from the posterior pituitary. But the key thing is, we've learned how to make it in the lab. We've synthesized it, which means we can use it as a very powerful, very precise drug.
Okay, so its main job, its day job, if you will, is contracting the uterus. And the uterus becomes super sensitive to it right at the end of pregnancy. But, and this is what you must remember as doctors, it has other important effects. It's what causes the milk letdown reflex during breastfeeding. And, listen up, this is critical. In high doses, it can act like ADH on the kidneys, causing water retention. And it can also hit the cardiovascular system and cause a sudden, dangerous drop in blood pressure. Never ever forget these side effects.
So where are you going to see this used every single day on the wards? Its #1 job in the hospital is to induce labor. That means we start labor when it's not starting on its own. Or to augment labor, which means we help it along when the contractions are just not strong enough to get the job done.
But, and I want every single one of you to listen to me very, very carefully now, you do not just hook a patient up to an oxytocin drip. It is not like giving paracetamol. There is a critical, non-negotiable safety checklist you must go through every single time. Is the baby's presentation correct? Is the head too big for the pelvis, what we call cephalopelvic disproportion? Is the placenta blocking the exit, placenta previa? Is the baby already showing signs of distress? Is there a scar from a previous C-section? If the answer to any of these is yes, it is an absolute contraindication. You do not proceed. Is that clear? This can save a life.
So why is this our go-to drug for induction? Simple. It's because it's so beautifully controllable and it acts just like natural labor. Number 1, its half-life is super short, like 6 to 12 minutes. So if the contractions get too strong, what do? You just stop the drip, and poof, the effect goes away very quickly. Very safe. Number 2, it gives you those nice rhythmic contractions. Contraction, then relaxation. That relaxation part is absolutely vital for the baby to get enough oxygen. And third, it's smart. It doesn't contract the lower part of the uterus, which allows the baby to descend properly. See? It just makes perfect sense.
I want this sentence to be burned into your brains. Injudicious use can be catastrophic. This is not just some line from a textbook. It is the absolute truth. Oxytocin is a fantastic tool, but it is incredibly powerful. You have to respect this drug.
And this is what happens when you don't respect it. If you use it improperly, maybe the dose is too high, or you're not monitoring the patient properly, the results can be absolutely devastating. You can get contractions that are way too strong, what we call hyperstimulation. This can literally tear the uterus, a uterine rupture. It can cut off the baby's oxygen supply, leading to asphyxia and even death. And don't forget that ADH-like effect I told you about. High doses, especially with lots of IV fluids, can lead to a condition called water intoxication. The patient's sodium levels drop, and it can be fatal.
So we end with this amazing contrast, isn't it? On one hand, we have the uterus, a process we have learned to start and to control with incredible precision and safety. And on the other hand, we have sperm production, a process that has completely stumped us for decades. It's a fascinating state of affairs, and it really makes you think, doesn't it? What do you think will be the next great breakthrough in this entire field of reproductive medicine? Something to ponder. Okay, thank you, everyone.